Well, good afternoon, everybody, and welcome to another one of our King Fahd Armed Forces Hospital Journal Clubs. It gives me great pleasure today to introduce the faculty that we have with us. We have Major General Dr. Faiz Bukhari, who's the Assistant Hospital Director for Medical and Technical Affairs. Professor David Cohen, who's also the Director of Clinical and Quality Research in the Cardiovascular Research Foundation, New York. And one of the investigators of the article that we'll be discussing today, Professor Vivek Reddy, who is the professor of medicine at the ICANS School of Medicine in New York. And we're going to be discussing a technology that's relatively novel to the community, which is dual chamber but leadless pacemakers. I think the initial data has been out. So I'll hand over to our moderator for today, Dr. Faiz Bukhari, and the rest of the team.
It's very exciting. Thank you, Mirfat. It's very exciting to talk about leadless technology. It's my pleasure to introduce Dr. Vivek Reddy, who's actually the second author for this landmark study. Vivek?
First of all, thank you so much for the very kind invitation. I'm going to just share my presentation, so please give me 1 second while I try to do this without screwing up. Okay, hopefully you're able to see my presentation right now.
Yes.
Okay,
it's in
fantastic.
the presenter mode. I think you have to go to display settings in the upper left there.
Yeah, so it's in the other one. Okay, so let me just switch the two. How's that?
Well, yeah, that's better. Yep, that's good.
Okay, fantastic. So what I wanted to do is spend a few minutes sort of discussing, providing a little bit of background about leadless pacing, how we got to dual chamber, and then go through the data. I'll try to do it in about 10 minutes. So dual chamber leadless pacing. Please note that I do have a number of disclosures. Specifically, I'm a consultant to Abbott, which is the company that makes this particular dual chamber pacemaker. So first, why dual chamber pacing, or why leadless pacing in general? And I think all of you know this. I'm going to go through this very quickly. There are problems with traditional pacing systems, including problems with the pocket as well as the leads. And there's also the other issue is the patient experience. And this is one that I've actually been increasingly understanding the importance of as we're doing more leadless pacing. It's very interesting that, when you have a chest scar, of course, the bump with the leadless pacemaker, it actually affects how people think about themselves. It's almost like now you're getting older because you have a device, and it's a completely different experience when you have a leadless pacemaker. It's almost like a stent that disappears inside of you, and you don't really think about it. And of course, there's of course in some patients arm movement restrictions, which tends to be less of an important issue. And then the more important issues like infection, hematoma, erosions, lead fractures, which can be problems. So because of this, there's been an interest in trying to get to a leadless pacemaker, that is a small encapsulated device that fits entirely within the cardiac chambers. Just really briefly as overview, and this is sort of a US focused study presentation, so I apologize for that. But these are the devices that have broad regulatory approval. Single chamber ventricular leadless pacemakers. There's also single chamber ventricular pacemakers that have the ability to sense a pressure wave from atrial contraction. So you can do ventricular pacing and have some degree of atrial sensing. It's not perfect, but it works in many patients. And then what we're going to talk about today, which is true dual chamber leadless pacing, meaning a device in the top chamber, a device in the bottom chamber, communication, sensing, pacing, etc. So how do we get here? Actually, the first leadless pacemaker, which is the precursor to the Avera device that we're going to talk about today, was called the so-called nanostim device. This is now, I guess, almost 14 years, since the very first experience. And that led to the very first large prospective multicenter clinical trial of this leadless pacemaker. And soon after that, almost simultaneously, there was the micro device, which actually did get FDA approved and has been used broadly. The devices have some differences. We can talk about it later, but the micro device received FDA approval as well as European approval and approval in multiple geographies and has been used quite a bit. What happened to the initial nanostem device? Well, there was a problem, which was there was a problem with the battery. And because of the battery issues, a lot of these devices had to be recalled. And in fact, one of the silver linings was that we learned that we actually could retrieve these devices, which becomes very important when you think about how these devices are dealt with over time. And just one very quick slide on this. This is almost 200 patients actually who underwent explantation after ventricular implantation. And you can see the time between implantation and explantation, in some over 6 years. And you can see the overall success rate is not really different. So at least out to about 10 years, the success rate didn't really change. It also was the same regardless of operator experience. So it seems like we can remove these devices very nicely. Okay, ultimately, the battery was redesigned and a more traditional design, and there was a ventricular AVEIR device, which is single chamber ventricular pacing, but that of course, and then that got also approved. But of course, what we really care about is dual chamber pacing because this addresses 100% of the market, while single chamber ventricular pacing really only addresses maybe 20% of the patient population. So the idea here is to have two devices, and they have so-called implant-to-implant or eye-to-eye communication. So with each paced or sensed event, there's an impulse that's encoded into that into the QRS complex or P wave that's sent, and then the other device detects it. It's all conductive communication. And so with each pacing and sensing, it's constantly communicating back and forth, which is very impressive. By the way, that also has an impact on battery drain, which we can also talk about. Ultimately, the idea is after the ventricular device, here you can see the atrial device still connected to the implant catheter. And here you see the two devices, one in the right atrium, one in the right ventricle. Okay, so, and then you can see it on X-ray, on the AP view, there's the atrial device, ventricular device on the lateral view. So let's look at the clinical trial that was published about a year ago. This is a prospective, multi-center, global, and importantly, single-arm trial. This is not a randomized trial. And the goal was to include up to 550 patients enrolled at up to 85 centers worldwide. The first 300 de novo subjects with implant attempts were used to evaluate the primary endpoints, and up to 50 upgrade patients. So patients who had a ventricular device already could receive an atrial device and hence become a dual chamber system. And then there was data collected at baseline, certainly at the implant, and at 1, 3, 6, and 12 months, and every 6 months thereafter. The inclusion criteria was relatively broad. It's basically patients who have dual chamber pacing indications, who are at least 18 years of age, and who have a reasonable life expectancy. The exclusions are things like IVC filters or mechanical tricuspid valve prostheses, patients who had existing systems, and there was a question about interaction, et cetera, though certainly in clinical practice, this is not an exclusion. A patient who has a non-AVEIR already implanted leadless pacemaker, and patients that had other stimulators, for example. Here's the consort diagram. There were 300 implanted patients, 2 implanted with ventricular only for various reasons. Ultimately, 298 patients that had both devices. There were 3 deaths before the 3-month visit. None of them were related to the procedure or the device. 295 active at 3 months, and all patients were analyzed for primary safety endpoint. 299 for the primary efficacy endpoint, which I'll discuss in a second. And I think I missed the slide. Anyway, and 294 for the second efficacy endpoint, which we'll get to. And again, there were a total of 55 sites in Canada, Europe, and the United States. Who were these patients? Well, you can see the mean age was 69, consistent with most dual chamber pacing patients, up to 90 and as young as 20 years old. About 37% were female. A range of BMIs, mean of 28, but ranging from as low as 15 to up to 49. The primary indication, as expected for a dual chamber device, was sinus node dysfunction in about 2/3 of the patients. 1/3 were because of AV block and other indications. You can see that there was tricuspid insufficiency prolapse regurgitation, 24% of the patients. And you can see that 8% had a transvenous lead extraction. And there were 2 patients actually who had leadless pacemakers previously implanted that had been extracted. And also, I didn't indicate this, but about almost half the patients had some sort of supraventricular arrhythmia, mainly atrial fibrillation. So if we look at the procedural characteristics, the overall success rate was quite high at 98%. The procedural time, the total procedure time was 70 minutes, and this is again skin to skin. Atrial implant, again, this was really the new aspect of the procedure for these investigators. These investigators had already been using the ventricular device, so that you can see the ventricular implant time was about 24 minutes. The atrial implant time was longer at 40 minutes. The total X-ray duration was 18 minutes. If you look at repositioning, meaning if you try to position the device at a location, you don't like that location and try to reposition it. So for the atrium, about 3/4 of the time, the first position was acceptable. And then in additional cases, there were obviously there were additional reimplants. And I should know, we can talk more about this later, we learned a lot, as expected, over the course of the trial. And we should talk about that more later. Ventricular repositioning, not surprisingly, the first position was a correct or adequate position. Again, recall that these investigators had previous clinical experience with ventricular devices. So the first position was acceptable in 87% of the patients, and then most of the remaining with the second position. If we look at the final location, for the atrial device, it was mainly in the appendage, in various aspects of the appendage. You can see over 80% were somewhere in the appendage. But there were other patients where it was either on the lateral wall or the posterior wall, particularly in patients who had previous cardiac surgery, where you had a diminutive or absent appendage. In the ventricle, you can see that it was usually on the septum, or thought to be on the septum, though we're increasingly finding that because it's a screw-in device with where one can do it in a very controlled way, you can literally put these devices almost anywhere in the ventricle, including the free wall. So this is the primary safety endpoint, and the freedom from complication, you can see, was 90%. The lower confidence interval was 87%, which exceeded the 85% performance criteria. So I think that's an important point. The performance goal was 85%. It was, and that was based on previous clinical experience with single chamber ventricular or dual chamber pacing technologies. Now, let's look at what exactly are these approximately 10% complications, because I think they're not all something that we're terribly concerned about. First, you can see the most common complication was cardiac arrhythmia. So during the implant procedure, if you see, for example, anyway, as you can see, a common atrial fibrillation. Usually this is short-lived, usually in patients who had atrial fibrillation at baseline. But the point is, because this is something that sometimes prolonged the hospitalization, this was called a complication. Another one, in 3 patients, another 1% of the population of the cohort, it was urinary retention. So let's look at the complications that we're more worried about. The most common was intraprocedural dislodgement. Okay, so in 5 patients, at the time of the procedure, the device dislodged from that location. In all those patients, it was recaptured, removed, and in most of those patients, the new device was implanted. There were also 5 additional patients with post-procedural dislodgements, meaning it didn't happen at the time of the procedure, but rather sometime during follow-up, the device had dislodged and then had to be retrieved after the fact. So that did require a second procedure in those patients. What about pericardial effusion? This is the one that we were actually the most concerned about, and surprisingly, the event rate was actually quite low. There were only 2 pericardial effusions. One required pericardiocentesis, and that was done percutaneously, didn't require surgery. And one was actually managed conservatively, so it was an effusion without tamponade physiology. So we were actually, I was quite surprised about how low that event rate was. Again, this is in the setting of a clinical trial, et cetera, but still, there were a lot of operators. So let's look at the other procedure or efficacy endpoints. On the primary end, the composite atrial capture and sensing. So that was achieved in 90% of the patients. There was, and then the other important analysis was AV synchrony. So you had to have AV conduction, AV synchrony, and that was achieved in 97.3% of the patients. This was an important secondary analysis. So there was at 3 months, the patients did a walking test, and as well as various types of positional changes. So sitting, supine, left lateral, right lateral recumbency, as well as standing, as well as a normal walk and a fast walk. And during these various times, the AV synchrony performance was calculated to try to understand how well this sort of eye-to-eye communication is working. As you can see, throughout these various postures and levels of activity, there was excellent AV synchrony at above 97% the majority of the time. So the conclusions from our clinical study were as follows. Number one, that the system itself was successfully implanted in 98.3% of the patients with the 3-month safety and efficacy endpoints that exceeded the performance goals. Number two, that the beat-to-beat wireless bidirectional communication, this AV synchrony that we just discussed, was successfully achieved in 97% of the patients. And there are also use cases of using either atrial only or ventricular only or combined functional system. There's some important limitations. The most obvious is the fact that this is a single-arm study with no randomization. So we use performance goals based on previous trials of conventional pacing systems. This data that was published here in the New England Journal was short-term data with only 3-month follow-up, and I'm going to show you a little bit more regarding this. The collection of AV synchrony data was in a clinical environment, and certainly we need additional data outside of that. Some of the ethnicity and race data was not collected from European subjects. After this initial study, we published additional papers looking at 6 months and ultimately 1-year performance of the technology. So again, this is the same study, patients being followed for a longer period of time. I'll just go through this very quickly. Basically, if you look at the capture thresholds, they remain quite good. This is an implant pre-discharge in 1 month, and we saw this in the initial study. But basically, after this point, you had excellent capture thresholds, the mean being less than 1. And if you look at P-wave amplitude, again, as you see with most of these devices, you see some improvement over the first month, and then stable P-wave amplitudes at above 3 millivolts. And even out to the 1-year time point, the success in terms of composite pacing and capture was good at 93%. If we look at the safety endpoint, and it's nice to see the Kaplan-Meier curve because it gives you an idea of that, the majority of these events happen early. They're really procedure-related or peri-procedure-related events. And after that, we see very little complications. We already talked about these dislodgements and the effusions. If you look at late, after 90 days, for example, what you see in terms of complications is not much. There were 2 additional patients with capture threshold issues. 1 patient had presyncope. There was a patient with heart failure. And there were 2 patients that had upgraded the device from these kind of devices to resynchronization devices. So that's an important issue that I'm sure we're going to also talk about. And if you look at eye-to-eye communication, again, the communication has stayed good above 90%. I also want to just touch base for a second on battery longevity, because I think this is an important point. If you look at the single-chamber devices, you can see that the battery longevities are quite remarkable. I mean, let's take a look at, for example, just look at the ventricular device for a second. If you're pacing infrequently, you can have battery longevities that exceed 2 decades, okay? Now, the atrial device is a little bit smaller than the ventricular device. The battery is physically smaller than the ventricular battery. But if it's pacing infrequently, so let's say backup pacing, for example, you can have extremely long battery lives. Now, conversely, if it's pacing quite a bit, yes, the battery life comes down. And very importantly, those are single chamber devices. When you combine the devices, and this is going to be a challenge that we have to deal with, when you have dual chamber devices, if they're pacing infrequently, then yeah, you can get pretty good battery longevities, okay? By the way, if you have very high pacing amplitude requirements, then you can get extremely low battery longevity. Look at this, just 1 year, okay? So that implant pacing and sensing thresholds are very important. Fortunately, this is actually extremely rare, as we saw in the clinical trial. But it's also an interesting issue that the atrial battery longevity and the ventricular battery longevity are different. So this is one of the things that we haven't yet been dealing with, but we will be dealing with in many years, which is when it's time to replace the battery of, let's say, the atrial device, and the ventricular device still has, let's say, 8 years of battery life, we're probably not going to want to replace both of them. You'll replace one of them, and then when it's time, replace the other. But anyway, this is an interesting issue. The other interesting issue is if we look at real-world experience, there's increasing experience with using an atrial-only device. One of the nice things about having this sort of modular approach is you can put an atrial device in, and then if for someone that has sick sinus syndrome, and then potentially at some time in the future, put in a ventricular device. And there's some experience with this. Let me skip that. And then for those of you that are interested, we did publish a recent review article in JACC, and I just want to talk. This is my last slide. I just want to talk about where the leadless pacing may be going in the future. One technology that's already in clinical trials, close to regulatory approval, is a leadless device that communicates with a subcutaneous defibrillator. So the idea is subcutaneous defibrillators are very nice devices. You don't have the same sort of vascular lead issues, but they have the inability to do anti-tachycardia pacing. Well, this is a technology where the device can communicate with the leadless ventricular pacemaker and provide sort of anti-tachycardia pacing. You can imagine situations where you have some sort of leadless technology in the left ventricle and do cardiac resynchronization therapy. This is still a little bit further away, but probably the one that we're probably most excited about, and probably also the furthest away, is leadless pacing that allows conduction system pacing and this is something that certainly is going to be very important in patients who have some degree of ventricular dysfunction, where you don't want to exacerbate the ventricular dysfunction with myocardial pacing alone. But also in other patients, there's probably about 8 to 10% of patients who, with traditional ventricular pacing, will develop some degree of ventricular dysfunction. And so this is something that I think all of us are excited about as a potential for the future, though it's not available yet. So with that, I think I'm going to go ahead and stop. But thank you very much.
Yeah, thank you. Very nice. Congratulations for this landmark study. Well, this is a journal club, so I have to ask a few questions maybe related to study and the design, and maybe David also, I'm sure, will have some comments later on. So the question that I have for you is, you mentioned 550 patients enrolled.
Yeah.
The original study, the manuscript in the New England mentioned only 300. So you excluded around 150 patients. Do you have the details and why not mentioned in the study?
Yeah, it's not that they were excluded. As oftentimes happens, the 300 or so patients were sufficient to provide a sufficient power to address the primary safety and efficacy endpoints. But one of the interesting aspects of this study is there were a lot of centers that were involved. There are actually very few centers that did more than 10 procedures. It was very widely diffused. And part of the goal was to allow centers to have experience and do more cases. So the study basically ran longer. And those additional patients were actually reported in one of the latter publications that we talked about. Again, it was an ongoing study at 300 patients. The data was cut, and we did all the analyses. But then additional patients were being reported in the latter studies. And functionally, there was no real difference. I mean, the data was very, very similar actually, in terms of performance and et cetera.
So 550 screened but not enrolled.
No. Sorry. No, 550 enrolled receiving the implants. What happened was, as the study was moving along at 300, the data was cut, and then it was presented and et cetera, and submitted to the FDA. But patients continue to be screened and enrolled up to 550 total implants or attempted implants.
Okay, got it.
Yeah.
I had a couple of technical questions around the study design, because there aren't that many single-arm studies published in the New England Journal these days, right? That's a very it takes a really unique study to do that. So congratulations on that to begin with. Was there any consideration given at the time when the study was designed to doing a more traditional randomized trial? And
Yeah.
I don't imagine it would have been all that difficult to enroll in because these patients would have all received dual chamber traditional lead pacemakers with
Yeah.
it. So was it and then where exactly did the performance goals come from? How did you guys derive those?
Yeah. So, and unfortunately, one of the slides I had was hidden, which is why I didn't go through that in details. I apologize. Let me address the first point. It's an important one. Look, there's no doubt one of the limitations is we're saying it works as well as traditional devices, but we use historical controls. So I accept that that's a limitation. The reason we did that is there are learning curves to these things, as expected. And I think it's reasonable to say, and we certainly felt it was reasonable to say it wouldn't be fair to compare leadless pacing, where we're doing this for the very first time, to conventional pacing, with literally the investigators had performed literally thousands of these procedures. Okay, so we thought it made more sense, and certainly, because this is such a novel technology and has a potentially huge impact. That's why it got in the New England Journal. But wherever it would have been published, the point was more that we thought that it was reasonable to do this as a non-randomized study, get FDA approval. But I think your point is still well taken. Ultimately, a randomized trial is going to be very important. And in fact, arguably, a randomized trial is going to be very important for insurers, particularly to rationalize paying for these more expensive devices. Coming to the actual the criteria, so the safety, so all of the complication rates were basically derived from relatively contemporary studies of traditional pacemakers. Okay, and so basically these are product approval studies from traditional pacemakers, dual chamber pacemakers that were conducted over a range of different company devices, and et cetera. Um, and obviously these things negotiated with the FDA, goes back and forth, and there's some performance criteria. Now, the actual safety complication was, and I didn't really define it carefully, it was basically freedom from system related complications in the de novo subjects, is as you'd expect. The efficacy was adequate pacing and sensing. So what does that mean? Adequate pacing was capture less than 3 volts at 0.4 milliseconds, and adequate sensing was a P wave greater than 1 millivolt. And these things were actually at the time of implantation. Okay, so as you saw, the success rate's like 93% or whatever it was. Those actually numbers improve over time, and we see this with traditional pacing technologies, but it's even more accentuated with the leadless pacing. So often, and one of the things that we learned over the course of this experience is that the numbers that you get at implantation are oftentimes not very good. You may have very high thresholds because there's a lot of injury that occurs with these very big devices that we're screwing into the myocardium. But what we're seeing is when you see the appropriate changes, meaning increase in electrical impedance as you screw it in, and you start to see a trend of improving pacing and sensing over the course of 5-10 minutes, those patients do extremely well by the next morning. So these are some of the learnings that we had.
Was the single arm nature, was that very controversial in both in the EP space and in the regulatory space, or was it really pretty accepted?
No, it was actually quite accepted. It was probably more controversial for us physicians than it was from a regulatory perspective, and so that made it. But I actually agree with it. I mean, I'm a big fan of randomized trials, and I absolutely 100% believe that we need randomized data in this space to really appropriately understand its role. Because I didn't show some of the slides, but there've been a number of propensity match analyses performed looking at leadless pacing, mainly ventricular pacing, because we don't have enough data with dual chamber, but looking at ventricular leadless pacing versus ventricular conventional pacing. And when you look at safety profiles, what you see is complication rates that are loaded up front for leadless pacing, but are much higher over even like over a couple of years for conventional pacing. It's about more than double the level of complication rates with conventional pacing compared to leadless, and those curves seem to diverge. Okay. Having said that, by the way, the mortality rates seem to be relatively similar. So the complication rates are mainly non-lethal complications. But these are all propensity match analyses. We need randomized data here, ultimately.
Is there, I mean, again, this stuff is so new. Always the challenge with randomization, as you pointed out, is the learning curve and sort of getting the things up to speed. And the analogy. I mean, I think about it relative to the interventional space where, I spend a lot of time designing trials and try to execute them for it. And, we are really, I mean, there is almost nothing in the interventional space in coronaries or in structural heart that gets approved without randomization these days.
Yeah.
And we accept the fact that the issue of learning curve and inexperience with the device. It's perhaps maybe we need to learn a little bit from you guys about being more willing to accept non-randomized data when it's so early. But typically what we do is just have longer sort of roll-in experiences and those sorts of things. If you look at the valve space is the biggest example of that we have. Usually takes a couple of years of developing some experience with the device before we're ready to randomize against either medical therapy or other procedures or those sort of things. So it's an interesting.
Yeah, the one other thing I'll say, David, there's been a lot of, I mean, sort of 50, actually now 70 years of experience with traditional leaded pacers, and those have all been approved. All these advances have been approved based on non-randomized studies.
Right.
And so in some sense, I guess we leverage that. On the other sense, yeah. So, but look, I think that I don't disagree that randomization is important, but I also don't fully think that I think that our rationale was reasonable, and I wouldn't say this about all.
Yeah, no, I think it's you have to pick and choose. I think you're pick where the issues are very well defined and the comparator is very well understood. That's a place where a non-randomized study could and here again your emphasis was really on mechanistic endpoints. It wasn't I mean the only one that was clinical endpoint was the complications, was the safety piece. That was the only one that was clinical. So I think it's really interesting. I don't want to dominate the conversation, but I've got a whole bunch of other questions here for after I let somebody else get a word in.
Let me continue the same, which is basically, I know that setting a boundaries and performance goal looks very elegant, but I think we need to do a head-to-head comparison between conventional versus leadless. Are you planning to do this, Viv?
I've been planning that for a while. But the question is getting the company to also plan that. Now, what's interesting, and actually there's a question I see in the chat, are any ongoing cost effectiveness studies comparing dual versus traditional? Look, there are some cost effectiveness studies that are being, sort of estimated, let's say, from retrospective data, but the limitations of those. Fortunately, I think the company is interested in doing a dual chamber trial. And look, you and I both know part of this is economic pressures, right? And in some sense, dual chamber pacing, I can tell you in the United States, it is certainly taking off, but it's not taking off perhaps at the rate that they were hoping. And there are a number of reasons for that, including, by the way, the cost of the devices, which is quite considerable. So I think that actually is a pressure to the company to do a randomized trial to prove actually that not only does the device work just as well as dual chamber conventional devices, which it will, of course, but also that over, let's say, a short and midterm and eventually long term, that we're seeing the actual reduction in complication rates. So, yeah, I've been playing it for a while, but I think the company is going to actually sponsor something like this. See, the problem is governmental agencies tend not to sponsor product trials like this, and for rightly.
But with Micra, they did it. With Micra, they did it head to head.
No, there's never been a randomized trial with Micra.
conventional versus.
Oh, yeah.
Oh,
No,
match.
no, not at all. Those are all retrospective studies. Yeah, yeah. So all of the single chamber approval trials for leadless have also been non-randomized studies with a lot of, uh, propensity matching. I did some of those
Oh,
also.
okay. So they use
There's
the
no
same.
randomized data.
They use the same performance goal, historical control, and so.
Absolutely. All
Oh,
of them have been the same. Yeah.
okay.
There's not been a randomized pacemaker study that I can remember in quite some time, actually.
20
But
years.
there are
I mean,
some that are
I was
ongoing.
involved in the most trial back in the early
Yeah,
2000s,
yeah,
right?
that's probably that and David. I mean, it's been a long time.
Yeah, that's the last one I can think of.
Yeah,
And they were, I mean, not that, I mean, they were easy to do. At least most was, because it was, again, both leads
yeah,
and just, randomized to on or off for dual chamber. But I mean, so let me kind of push on a couple of things, or not push, but just probe, honestly,
yeah,
on it. So I'm curious about this 70%. The threshold for AV synchrony was, you had the definition of AV synchrony was 70% or greater
yeah,
synchrony. And so, and I'm just curious what that, first of all, what does it mean? And secondly, again, is that, is that the right definition? It doesn't sound like it's very good, but, again, you achieved it in a high percentage of patients, but it seems like,
yeah.
you could be 25% non-synchronous. Does that mean that the synchrony is not working if you're at 75%, or is it just by the nature of, intrinsic conduction takes it out of
Yeah.
play? I mean, so
Yeah, it's the latter. I mean, there's actual synchrony that defined by the way that you have the impact communication, everything else, and there's functional synchrony. That is, even if you doesn't actually communicate, you can still have conduction, or the timing maybe just happened to be right. So
accidental.
we're focused on the former. Okay, um, yeah, that's 70%. Uh, I was surprised that we were allowed to get away with that number.
Okay. I mean, Pius, does that bother you? That 70% was the threshold. Does that feel right? Again, this is, me as an interventional cardiologist who, knows, all I know about pacemakers is the phone number of the EP guys, so I can have them come and help me put one in after a TAVR. But what is the view in the EP community?
Those numbers for me looks very elegant and nice and beautiful, but for me, I look at the patient more than the numbers, and our experience with the leadless is quite amazing. The numbers are good and actually tend to improve with time rather than deteriorate with time. So
Yeah, that was
Yeah,
a surprise to me. I didn't realize that the thresholds and everything would get better over time. I thought that they would get worse, but that's, again,
no,
because
they get, yeah.
experience is with temporary pacing, which is a completely different animal.
Yeah, and part of it is that when we implant the device, we're at the end of a very, let's say, a bulky system between the catheter and the device itself. So there's a lot more injury that we see with leadless pacing than with conventional. Just one point. Look, I think, again, you can argue about the performance goal, and I certainly have a tough time defending that specific one. But functionally, what actually has happened is very high synchrony. So we're happy about that. If our actual synchrony was 70%, I don't think we'd be very happy.
You wouldn't be excited, yeah, about the
No,
device.
that's a completely different animal.
So let me get, again, a little bit outside the realm of this specific paper, but two questions sort of related to practice, both for Fayez and for Vivek. Maybe I'll ask Vivek first and then Fayez. So of patients currently, if you think back about how long has this been approved in the United States, this particular device?
Yeah, just over a year approximately.
Okay.
And I think it's been approved like a year, almost a year and 3/4. But then there was a reimbursement that started a little bit less than that. Yeah, so just over a year.
Yeah, so thinking about the last 6 months or something like that, what are the statistics on the proportion of patients who receive dual chamber pacing, either conventional or leadless, that are getting leadless these days in the United States? And again, I recognize that maybe a lot of this is financial, but I want to just understand how much use there is.
Yeah.
The companies aren't getting as much maybe as they hoped they would get, or the company from it. But help me understand what its utilization is.
Yeah, it's very spotty, and I don't have real data, okay, but let me just give you my stuff. So one of the very important issues is there's a significant training requirement, okay? And the training requirement is not just, oh, look at a couple of PowerPoint things. It's PowerPoint
It's
plus
very difficult.
yes, it's an
Lots of
in-person.
steps.
Lots of steps, yeah. It's an in-person visit. You're doing a preclinical, actual animal lab to understand how to implant. So, in fact, in my institution, um, not all the EPs are actually trained.
Hmm.
And it's not that they don't want to be. Everybody wants to be, but they can't. And I'm not allowed to train them myself, even though obviously I've done a bunch of these. So it's been slow the rollout, okay, which is also a good thing and from a safety
Yeah.
from some perspective. Um, and the other pressure that there is the kind of patient. So if a patient has some degree of LV dysfunction, for example, we will not put a leadless device if we think there's going to be a lot of ventricular pacing because of the potential for, worsening dysynchrony, et cetera. So patients who are more on the sick sinus side, leadless pacers we're putting in quite a bit. Oftentimes, as I said, an atrial only device. Okay. In fact, that's oftentimes our go-to. Patients love the leadless. I'm surprised how much more they like the leadless devices. Um, uh, so in centers like ours, we have a very high leadless pacing implant rate. Probably of eligible patients, I mean, it must be three quarters plus. Okay. But we're probably an exception because there's not too many centers that have actually, been trained. So this is an
Yeah.
ongoing
Still,
thing.
at this, a year plus after
Yeah.
the
Yeah, year plus
Safias,
after.
tell us about the experience in Saudi or, in the Middle East.
Well, in the Middle East, we actually presented the single chamber AVER data at the ESC, and we did around, I think, 70 patients overall, in very highly selected centers in Saudi. Uh, when it comes to the dual chamber, we are the only center doing this, and we have done just quite a few numbers, not a lot.
Are
Uh,
you,
the
is it your
steps,
dominant form of dual chamber pacing at your center now, or is it still the minority?
dual chamber, yeah, almost always dual chamber. We are not using AI single chamber
No,
device.
but I was asking the other question. So, of people getting dual chamber pacing in your center, are most getting leadless or are most getting traditional?
Now, conventional, traditional.
Still more conventional. So you're not 75% like Vivek's center.
It's very demanding. The technology is demanding and so many steps. And imagine you are actually screwing a device in the appendage, which we were taught not to touch, even the wire. So, but eventually the comfort level actually increased, and now we are doing it very quickly in 30 minutes or so. But
That's
we used to do it in 2 3 hours before, but not only.
yeah.
So I
The
think the learning curve is easy, not a difficult learning curve, but you have to do quite a few numbers, at least maybe 10 patients before you get comfortable with the technology.
And then tell us about, but either, I mean, maybe Vivek about removal of the lead. So, or repositioning or capture, all of those different
Yeah.
things that do happen from time to time. That, and less about the ones sort of intra-procedural, because it sounds like the intra-procedural, you still have like a tether on it, and then you can just easily recapture twice.
No, it was also so the ones we defined as dislodgement was after
Okay.
implantation. So that was actually it's actually the same type of thing. But yeah, let's talk about that. So when you're talking about removal, so a device that's already fixed there, there's a dedicated tri-loop snare. So it's a snare with three little loops that
And snare like
both
that.
see. Yeah, I like that. And on the back of the device, I didn't really spend much time talking about it, but there's like a little hook type thing. And so when you go behind it and you grab onto it, it sounds like it could be complicated. It's extremely easy. I mean, from the very first time people are doing it, you can do it fairly quickly. Now, when do you fail? So there are a couple of times that we've seen failures. One time is if the device is positioned relatively proximally and the back end of it, let's say, is underneath the the tricuspid apparatus, then there have been a couple of cases where you couldn't get underneath there to actually engage this. And then the other is, look, there is a rate of encapsulation of tissue growth, okay? If the device is sticking up, okay, we've never, even after 10 years, we've not seen any significant growth, okay? But if the device is lying flat, let's say against the inferior wall of the right ventricle, okay, then we've seen a couple of cases where it's completely covered with fibrotic tissue. You can't get it out.
Yeah.
Now, of course, at that point, it's like, why do you care, right? Because it's the amount of space this thing takes is less than 1 cc. These are not, bulky devices. And so in that sense, it doesn't matter. Now, the interesting question is going to be, as we get away from dual chamber devices, we have get away from ventricular devices, and we also have atrial devices. How difficult is that going to be? There's a manuscript that's I don't remember if it's published yet, but certainly it's been submitted from from this experience of, and I don't remember the exact numbers, but I think around 10 patients who had atrial devices, and they were all removed. They all could be removed, and safely and whatever. So with the atrial device, the experience is much earlier, but it seems like it's also possible. And part of the reason for this high rate of success with removal is that the device was designed like that. So when the retrieval catheter mates to this, and when you rotate, you have very high torsional force that you can exert. So it's very easy to rotate. So the key is, can you engage the back end of it and actually grab onto it? Because if you can, it's coming out.
Okay.
That seems to be the key.
I think that you just answered the question that I had, which is, why is it shaped the way it's shaped? Because again, it just, I don't know. I wouldn't have thought that it would be such a, it's, rather lengthy. I think I read it. Like they're like 3 centimeters long. It's like, it's like this big, right?
Yeah, exactly. And part of the reason, of course, is, look, we're trying to put this through a venous puncture, right? So you got a battery, and most of that's battery, right?
Okay.
90+% of that device is battery, and the electronics are trivial.
It's like a Tesla. It's all battery.
Yeah, exactly.
Very powerful battery, much better than Tesla.
That's
so.
Yeah.
No, it's
And so that's part of the reason it's lengthy, because you need to have it small enough that you can go and I can talk about this, but it's around 23 French venous puncture, which a few years ago was somewhat daunting. Nowadays, this is like between the lead,
everyday microclip, everyday LAA, they're the same size.
Exactly.
Viv, let me ask you about the risk of dislodgement. For me, that's the most worrisome complication, and it's very high. It's like 5%. I think this is related to the 3% intraprocedural and 1.7 within 1 month. Do you think this is related to the learning curve, or you think it's related to technology, and how can you make this less? Because it's very hard to convince an electrophysiologist to implant a device 40 centimeter length into the appendage, knowing that you have a 5% risk of dislodgement.
So let's be clear. The rate of dislodgement included both the atrial and the ventricular devices. It was 1.7 acutely and 1.7 chronically. So it's still high. I'm not trying to say it's not high, but it's not 5+%. But it's 3.4%. One of the things that we learned over the course of the experience is which we didn't know really understand initially, was that when you implant the device, the most important parameters are watching the change in impedance. It's more obvious in the ventricle, but even in the atrium, as you rotate the device, because you rotate 1.5 turns, to implant the device approximately. And as you rotate, you need to see an increase in the impedance. In the ventricle, the impedance can be 300-400 ohm increase. In the atrium, it's usually more around a 50 to 70 ohm increase. But if you don't see that reproducible increase in impedance, if you don't see, for example, when you're implanting the ventricular device, as you rotate, initially there's like a lag in terms of the rotation. because the torque is building up and there's resistance from the tissue. If you don't see those cues, then what we learn very quickly is you're not in good position. You just do it again in a different location. And what I can tell you is there was a recent presentation, I think a publication, I can't remember if it's out yet, of looking at 5 or 7 centers since FDA approval and collecting their full experience, and there were no dislodgements in that experience. So I'm not saying there's not going to be dislodgements. I mean, it's still going to happen, obviously. But I think that there has been a very important learning, both per center, but more importantly, per the community in terms of what you need to pay attention to, which we didn't know before. But look, your point is still well taken. We're going to need to see, the prospective registries, the larger registries, and really try to understand if that rate has really dropped as we see this elaborated in the community.
So Faiz, if it's okay, I'm just going to ask a couple of very quick questions, and I'm going to try to circle this back to research a little bit in more broad terms. So when we do trials to get devices, particularly novel devices approved, particularly with authorities like the FDA and so on, we cherry pick centers and high volume operators to make sure we give these devices the best chance and the highest safety profile. So what's the role of post-marketing registries to see how they perform in the hands of real operators who are out in the real world? And the next question here is, when we look at sponsored research, there's often a misconception that these are biased and so on, which is not true. Sponsored research, in my opinion, means you're giving the trial the best chance at funding, which is necessary to get your core labs and so on. And there are always checks and balances in the making that kind of ensure that the research methodology remains intact. So if we can comment on those 2 items, because I think they are important as we design future trials.
Yeah, sure. So I can start. So remember in this trial, let's just talk about the initial published data. We had, of the actual 300 patients were implanted, we had 55 centers that enrolled patients. So that's an average of only 4 devices per center. So this is not one of those trials where, the majority of patients were enrolled in 5 centers and you have the stragglers enrolling 1 each. That didn't happen. In fact, the highest enrolling center was 20, I believe. And then there was a big step down to under 10 for the remaining. So I just want to say, now, having said that, you're still right. These are 55 centers that had experience already with putting ventricular leadless pacemakers in. And presumably they were all, good operators, and they were. And so I 100% agree that you got to see how, these post-market studies are very important. One of the things in the United States, there is a mandated by CMS that every patient getting a leadless pacemaker has to be enrolled into this post-market ACC's run registry or NCDR registry. So that is happening, has been happening with the single chamber devices, and is continuing to happen with the dual chamber leadless pacemakers. So and now we haven't seen any of that data yet because it's too early, but we will see that data for the dual chamber devices. And with regards to bias, look, there's biases everywhere, and I accept that there's, and you could argue that there was a bias in the design of this trial being a single arm versus a dual arm device. There are biases in both directions. I want the device for my patients so I can start using it in patients. I also want, by the way, a randomized trial to get done. And I happen to agree that it makes sense in this particular instance, not all, but in this instance, that we should have some experience by the operators before we do a big randomized trial, because I think that's a more relevant clinical question. The one nice thing about FDA trials is there are a lot of eyes on these studies. So it's malfeasance is very hard to do, whether it's by the company or by investigators in these kind of trials.
Yeah, I think I would just add, Mirbad, you asked a really great question there about understanding industry sponsored versus other types of trials, and they're obviously they are different. Again, the industry trials, as Vivek just noted, tend to be the early ones because they're the ones who know the technology, and they're the ones interested in getting the things approved, and so they have a lot of incentive to fund the initial trials, and then usually the government-funded studies like NIH trials or National Health System in the UK or something like that come along later once the device is established, the practices are better worked out. And the place, I also completely agree with Vivek that, the rarely in these industry sponsored trials are there, malfeasance or issues around the way the data are collected or those sorts of things. They tend to be extremely, extremely rigorous. But the places where you do need to look, and again, I don't think it's a bad thing, is in the design of understanding how the study was designed, what it does and what it doesn't inform. Because a lot of times the endpoints are, they're not necessarily the ones that one would choose if you were designing a trial completely on your own, or had an infinite budget and infinite time to design the perfect study. No studies are perfect; they all involve compromises, and so I think we do have to recognize those aspects, and that's a very important part of the physician community and the medical community in general. Being able to read these studies and being able to look carefully at the endpoints and say, are these the right endpoints? Were they defined well? Those sorts of things. That's where, if people are asking me how to, where should I look for challenges in a clinical trial or issues with the trial, it's never in the results. It's in the methods. The methods are where people design trials to, succeed or fail, and where those aspects are most clear. And so that's where you really need to focus when you're reading the literature about these kind of trials, is read the methods really carefully. Make sure you agree with them or understand the limitations of them.
One last question from the audience is, who will benefit the most from the technology?
Yeah, I think
no, just kidding.
That's true. No, but I think, look, I think the patients that have had lead complications are easy ones. Patients that have lead complications oftentimes will have it again, fractures and stuff like that. And certainly, anytime you have concerns about infection, right? That's a real issue. And I think that in the dialysis page, actually, I see the question. Yeah, dialysis, cancer, immunocompromised patients who've had previous infection are excellent candidates, I think, for leadless pacing. So yeah, if you can talk now, and then let's talk about the other extremes, right? I mean, there are patients who are very young who you could argue, well, you don't want them to have a life of dealing with leads. Conversely, there are patients who are very old, and I have to say, putting a leadless pacemaker, once you have experience with it, ends up being a relatively simple procedure. In terms of you're going through the vein, there's no surgical incision. There's some advantages there also. But again, this is why we need a randomized trial, right? Because that's where you really tease out these differences. If you had, and a randomized trial would have to be a big trial. This is not a 300 patient randomized trial. It should be several thousands of patients that where you can actually try to really understand who's benefiting. And by the way, who's going to do worse with leadless pacing also.
Yeah, I mean, a lot of questions to answer, but it is fascinating to me. I mean, again, the whole technology is amazing. I mean, it is really miraculous that the engineers can fit all this stuff into these little devices at this stage.
Yeah.
It's quite revolutionary to see it. And I was really impressed with the battery life data. That looks.
Yeah.
I would have. That was my initial worry: is how do you cram enough battery into these devices to make them work? And I guess the answer is. Be creative. I don't know how they're doing it.
Yeah, there's also, I didn't mention this, but one other important point that is the company just released some recent software, which can also be retrofitted, by the way, where in patients that are mainly sick sinus syndrome that don't need much AV synchrony, you can go to a mode where it's AAI in the top, in the atrial device, and it's backup VVI in the bottom device. So you don't have as much implant-to-implant communication. So when you do that, you can double, even triple battery life, because that communication is one of the areas where you're using that battery. So there are even some software things that are being advanced in order to maximize battery. So that's something that just got implemented in the United States, got approved regulatory wise. And so in all of our patients, we've been putting that in that are relevant.
No, that sounds great too. Well, I mean, again, to me, as someone again who doesn't live this life, these are really remarkable accomplishments, and I think the field of EP and you, Vivek, with your leadership on so many things, really should be congratulated on bringing these things forward for our patients. Now we just have to see if we can make them affordable, so that more can get them.
Yeah.
We have to make it.
That's a harder one.
That's out of your specialty, huh?
Yeah. Well, you know what?
Well,
The best way to make things affordable is competition, right? So
yeah, that usually helps. Although, something you would think that, I mean, there are areas where it doesn't seem to have changed so much, like in the valve space. We're still paying a lot, even though we have multiple devices for those. But in stents, it worked. Stents are now very, very cheap. And hopefully these devices will again get cheaper over time. Although the EP community always finds some way to build in more bells and whistles to keep, the new and improved, smaller even. Who knows what the next one will be for? But it's really amazing. So I'm really excited about this possibility.
And Viv, I think the competition now it's over, because I heard that they could not make other company failed to compete.
You mean in terms of dual chamber?
Yes.
I think I think they're looking at different ways. I mean, there are it's now publicly known that
the TINES methodology design failed.
Yeah, so there was putting a tine approach in the atrium was more challenging, but I know, for example, Medtronic has published some preclinical abstracts where they have a single device in an animal study that you screw in from the right atrial perspective into the ventricular septum, into the crest of the ventricular septum. So you can get atrial sensing and ventricular sensing from a single device. Now, presumably they'll move forward with that clinically, so we'll see. So I don't know that the competition is gone. I think the competition may look different. Let's put it that way. And there's other interesting things. I'm aware of a small company that's actually, the heart moves with each heartbeat, right? That movement could be harvested for energy. So there's a company that actually has an energy harvesting pacemaker that they're working on, so that with movement it keeps going. So you could get even more prolonged battery life, or you can some of the trade-offs we have now we may not worry about as much. So there's some interesting.
The watches that would charge themselves by your motion.
Right.
That's
right.
That's smart.
Yeah. So I think there's still innovation, but we'll see. It may look different.
Sure. So, Mirfat, any final remarks?
I mean, this was fun. It was, a lot of clinical discussions on what's in the horizon, what to expect from this new technology, but also, dissecting the methodology really of this trial and the study results. So thank you all for your time, and the time difference, it's way early in the morning at your end, but we're looking forward to another episode. And for our attendees, stay tuned. We're going to have a lot more of these journal clubs around the corner.
Thank you, David. Thank you.
No, thank you. It's now.
Thank you, everyone.
It's ready to get to work now.
Yeah, exactly.
Have a great day, everybody.
Thank
Bye,
you.
everyone.
Bye.
Bye.